Howdy guys, we're moving right along here. The next section we'll be dealing with are the epilepsy and seizure-like disorders. Now when we go over the epilepsy and seizure-like disorder section, of course we're going to talk about epilepsy itself when we have a tendency for unprovoked seizures in a recurrent fashion. So recurrent and unprovoked seizures, when we have this tendency, that's when we use the diagnosis of epilepsy. When we talk about epilepsy, we break it up into several different categories, and that's what we're going to do. Now, we should mention at the outset that epilepsy has a lot to do with problems that happen in the cortex of the brain, so the outer covering of the brain itself. They generally occur abruptly, so all of a sudden, and then what we are listening for is what the patient experiences, what we call the phenomenology of what is going on. A patient can have a taste of metal, a smell that is very disturbing and almost perverted, and then yell. A patient may have their hand shoot up, or the head may turn, the hand may go to the mouth, and then this may turn into something else, or a full-blown seizure, or not at all. So that's what we call the phenomenology of the seizure, what the patient feels and what they actually do and what occurs, the phenomenology. So we'll go through that. Now, we'll talk about the temporal lobe seizures, the hemispheric, or rather, the hemispheric seizures, and most of those are temporal lobe. More than 70%. The next more common is coming from the frontal lobe, frontal cortex. Again, seizures come from the cortex. There's an exception, and that's absence seizure, and we should certainly remember that. So we'll talk about the hemispheric seizures in epilepsy, those like temporal lobe, frontal lobe, benign Rolandic seizures is also a hemispheric type of seizure. We'll talk about then the generalized seizures, so the myoclonic seizures, the generalized tonic-clonic seizure, juvenile myoclonic seizure, and then absence itself. We'll go through those. After we talk about and differentiate the hemispheric seizures from the generalized seizures, and what we're talking about is the onset, and then, of course, the medications that are used. We'll talk a little bit about the examinations, and then the EEG, and then the imaging implications. Then, when we do our course, we will talk about a more challenging situation and when seizures don't stop. Like most seizures are over within 3 minutes. And so when we have a seizure that lasts longer than 3 minutes, we call it status epilepticus. It's usually not going to respond to the same everyday old approaches, so we can't just take another dose of medication. In that case, there's a certain management, so we're going to talk about status epilepticus when we do our course. We will talk about then psychogenic seizures. Many times it's not because of a cortex problem, but many times we become overwhelmed with what's going on, and then that gets manifest as a psychogenic non-epileptic seizure. Very common. We see that, and we'll talk about some of the hallmark features, some of the features that are very, very suggestive that a person is having a psychogenic non-epileptic seizure event. It's very important because if we think that a person's having status epilepticus, then we can make them toxic medications that are not only going to be not useful, but it's actually going to make the situation more challenging. We'll go from that to talking about syncope. Now, usually when patients have a seizure at home, they don't remember the ride to the emergency department. They don't remember, and they didn't participate in the discussion of calling paramedics or 911. Many times they wake up in the emergency department and they really start having a remembrance of what's going on when they're in their room. So this happens. They may have a tongue bite. It's a more complicated event. But when they have a syncopal episode, it's brief. It's 20 seconds, 10 seconds, or even briefer. There might be disorientation, but it's more like, oh, wow, what happened? Where are my glasses? And then somebody might say, do you want me to call 911? And then we're like, no, we don't want to go to the ER. So it's a briefer event. So we're going to talk about syncope because sometimes it's not that straightforward. So that's why it's in the seizure-like disorders section. We will then talk about pregnancy and seizures because we can't just treat them with any old medication, so that deserves a section in and of itself. All right, so we're moving right along. If you're not studying medicine, if you're not studying neurology, somehow if you're not interested, well then this is probably a lot of information. This is meant to be an educational tool. It's an orientation, but it's also an educational tool because the more times you hear it, then the more likely you are to learn it and retain it. So hang in there, you're doing great. See you next section. And again, look for this entire course on twc.online and look for the art of neurology because that is what we are studying and practicing. Keep winning, guys.